My name is Marco Metra. I have the privilege to chair this session with Professor Frank Ruschitzka from Zurich. It's a very dense session. I mean, you will see the highlights regarding heart failure and valvular heart disease in the European Heart Journal and in the European journals. You see that there has been a steady increase in the number of publications regarding heart failure. In only 5 years, we have had a 40% increase in the number of publications in PubMed, and the same is occurring with valve disease. Again, in 5 years, a 46% increase in the number of publications. Why are these two conditions so important? Surely one major cause is aging of the general population. And then the other fact is that we have treatments, new treatments for these conditions, either chronic heart failure and valve disease. And therefore, and the third reason is that there are associations and the European Society of Cardiology which are supporting research and progress in this area. Therefore, enjoy the session. I'm just introducing, and I can introduce now Jeroen as the first public presentation. Jeroen, regarding cardiovascular imaging.
Thank you very much. It's my pleasure to be here with you. It was hard to find specifically articles on the topic of heart failure and valve disease. So what I've done is I looked through the European Journal of Cardiovascular Imaging, and I picked out some articles that I think are of interest for you. Some relate directly to heart failure or valves, some are a little bit more distant, but these were the ones that I thought were quite interesting and direct a little bit where the field is going in imaging. I did not touch upon the European Heart Journal because I know Alec, Vahanian, and also John Mcmurray will mostly touch on that, but I thought the imaging journal they will usually not look at. So here we go. We have 3 imaging modalities, and these 3 imaging modalities, as you know, include echo, CMR, and the third one is split nuclear CT. But what we start to see in imaging is that this fusion imaging is becoming important in the daily practice. So we fuse nuclear with CT. I'll show you a couple of examples of that. So the first article I took is this one. It is by Dr. Debonaire and published in 2015. The title is Leaflet, Mitral Valve Leaflet Remodeling in Functional Mitral Valve Regurgitation. Characteristics, determinants, and relation to regurgitation severity. So I give you a quick summary, and then I take out 1 or 2 graphs or pictures of that article. So what is this? This is a 3D transesophageal echo analysis looking at functional MR in 34 patients. The patients are having either severe mitral regurgitation or mild to moderate mitral regurgitation. So 20 controls are also included, and all the patients had leaflet remodeling as compared to the controls. With MR, we see that there is an increased leaflet area. The leaflet is stretching itself because the ventricle is getting larger, so the leaflet becomes thinner but stretched. So the area, the surface area, gets larger. This remodeling, as we refer to it, relates to the reduction in LV function, which results in increased LV sphericity. The ventricle gets bigger and dilates in different directions. We therefore get an increased mitral valve tenting volume. The leaflet itself gets retracted into the ventricle. So actually what you see, normal you have a mitral valve like so, but in this case you get a mitral valve like so. It's really retracted into the ventricle. That is the tenting. And then we see an increase in annular dilatation. There is a larger annulus. The leaflet remodeling, if you want, is needed to adapt to the mitral regurgitation. And if it doesn't adapt, which we see with more severe mitral regurgitation, then we see less leaflet remodeling. The leaflet is simply not adapting. So how do we measure that? We use new technology. In this case, 3-dimensional echo, 3-dimensional transesophageal echo, where we measure these different things. And this just gives you an example how we can assess tenting areas, leaflet areas, annular areas, all of the things that I mentioned in the previous slide. And what we see is this whole thing here in blue and orange is actually the leaflet. And you see that this is the mitral valve exposed area in blue, and this is the mitral valve coaptation area, what I just pointed out to you. And what we see in functional MR, that the total leaflet actually gets larger. It has to stretch itself. But what we see in severe MR, that it's actually getting not large enough. It cannot result in good coaptation. So patients with functional MR have a larger total mitral valve leaflet area as compared to controls. It's stretching itself. That's called the leaflet remodeling. The leaflet area and the coaptation area are smaller in the severe functional mitral regurg, which indicates that the valve is doing its best, but with the stretching of the ventricle, it can simply not function enough. This is another one on echocardiography that I selected. Exercise echocardiography and cardiac magnetoresonance to predict the outcome in patients with hypertrophic cardiomyopathy. Here you see the study details, 148 patients with HCM, 7.1 years follow-up, and the events they looked at are death, cardiovascular events, stroke, arrhythmias. They use exercise echo to look at wall motion abnormality induction, which is actually a measurement of microvascular ischemia, probably. Then they use CMR to look for perfusion abnormalities during stress, which is also a marker of ischemia, and they use CMR to look for scar tissue. So the combination of an abnormal exercise echo and an abnormal CMR was extremely predictive of worse outcome. My question when I read the article, what determines really the prediction? Is that the fibrosis or the infarct or scar formation that we're seeing in this HCM, or is it the microvascular ischemia? Here you see the graphs. So you see here CMR positive, meaning ischemia induction and some fibrosis formation, and at the same time exercise echo being positive, these patients have the worst outcome. The patients that have a very good outcome, having nothing abnormal on the CMR and nothing abnormal on the exercise echo. And then these two groups are in between. My take home from this is if it's purely normal, no fibrosis, no scar formation, no ischemia induction, you are fine. If there is scar formation, induction of ischemia, the outcome is much worse. Again, what determines the outcome? Is it the ischemia or the fibrosis? That is unclear. So here you see the chi-squares, clinical variables, resting EF, the percentage of left ventricular on MR with scar formation makes the model more predictive. But what we really see is clinical variables, resting EF, and the increase in wall motion score index is much more predictive. So you get a hint here that microvascular ischemia is probably more predictive than outcome than just looking at scar or fibrosis formation. The next article that I took is the quantification of aortic regurgitation using high pulse repetition frequency 3-dimensional color Doppler. So we see that echocardiography is moving away from 2D to 3D. 29 patients with mild to severe AR. The gold standard is the regurgitant volume or fraction by MRI. And this new methodology is the vena contracta area measuring automatically by combining the Doppler power from multiple beams. So not just from one beam, multiple beams to provide you an absolute measurements of the vena contracta area, which is the area related to the regurgitation. Here you see on top standard 2D images, apical on the left, parasternal on the right, and you see on the bottom part the multi-beam HPRF apical and parasternal views. What they do is they sample very quickly. So here you see the sampling from the vena contractas during one heartbeat, 6 diastolic frames. Diastolic because we're looking at AR. And you see here that they sample all these different frames. And based on that, you can get a much better quantification of aortic regurgitation. Here is the comparison between this new methodology and MRI, and you see that it relates quite well. Going from 2D to 3D is my message to you relating echocardiography. What about CMR? CMR is really shifting towards fibrosis imaging and scar tissue. This one I thought was interesting. Late gadolinium enhancement identified with CMR in sarcoidosis is associated with long-term outcome, ventricular arrhythmias, and sudden cardiac death. 106 patients with either cardiac or extracardiac sarcoidosis. You see here the follow-up, 36 months plus or minus 20 months. And events they looked at is a sudden death, tachyarrhythmias, and if they have an ICD, shocks on the ICD as a surrogate endpoint. Cardiac sarcoidosis was, as we anticipated, correlated with poor outcome. Extracardiac was actually related with good outcome. Here you see the prognosis of the extracardiac, which is very good. Here you see the prognosis of the cardiac sarcoidosis. So what they look for, and that comes back in the second two presentations also about MRI, they look for this diffuse fibrosis. How do we do that? The technique, and this is one for you also to take home, is the T1 mapping in dilated cardiomyopathy. That is what people do, T1 mapping. And with that technique, you can quantify the extracellular volume. What is the extracellular volume? That is the diffuse fibrosis happening in the ventricle. So not big scar formation, is the diffuse fibrosis. And this is probably early markers of disease related to events also. So this study looked in dilated cardiomyopathy with the CMR T1 mapping, quantification of myocardial fibrosis, and compared it with biopsies. That's the first step we have to do if we want to start working with this technique. 45 mild dilated cardiomyopathies, 29 severely dilated cardiomyopathies, 56 controls. So CMR, to detect with the T1 mapping technique, I don't go into the details, to detect extracellular volume. And they correlated with biopsies. They show only in this study, first step, strong correlation between ECV and fibrosis on histology. Here you see the histology samples. Here you see these MRI techniques, and these color codings indicate more or less fibrosis. And this is what they saw. In the controls, there is very little fibrosis. The lower they are here, the less fibrosis there is. In early dilated cardiomyopathy, there is some fibrosis. It's a little bit more on average than in the controls, but you see also a huge spread. But if you then look at the severely dilated cardiomyopathies, the extent of fibrosis is getting much more. So fibrosis imaging is an important marker in many diseases. So this is the third MRI article that I took, a comprehensive evaluation of myocardial fibrosis and hypertrophic cardiomyopathy with cardiomagnetic resonance imaging, linking the genotype now to the fibrosis. So fibrosis is the phenotype, and now we're relating with genotypes. 139 HCM patients, 65 genetically mapped, T1 CMR again to assess diffuse fibrosis. You cannot see that, they just quantify it. HCM myectomy in some patients, and from the biopsies, that's the first step in the article, they compared with histology, similar than the previous article. And then the next step is related with the genotyping. The thing that they saw is more diffuse fibrosis in HCM versus the controls. So what we expected, what we saw in the previous article. They also saw that genotype plus versus CMR was related to very much regional fibrosis, but not so much global fibrosis. So genotype positive seems to indicate in special parts in the ventricle fibrosis start to occur. I ask you, what's the clinical meaning of this? We need to learn more about that. I show you. Here are the biopsies. You see the more red there is, the more fibrosis there is. They took them again during surgical myectomy. You see there's a good relation between the biopsy here and the MRI T1 mapping on the other. That's confirming the previous study. They take it then one step further and they relate it with the genotyping. Here you see the controls, and the higher up they are, the less fibrosis there is. So you see here that there is more fibrosis, and there is the most fibrosis. So the red is the genotype plus, and the green is the genotype minus, not to be genotyped. You see that actually there is more fibrosis in the genotype minus, but it's not at the special regions, as it is with the genotype plus. Again, what it all means, I'm not sure. But you see in MRI, the big thing is going to be T1 mapping measuring fibrosis. Left atrium, left ventricle, relating to valve disease, relating to outcome in hypertrophic cardiomyopathy, relating to atrial fibrillation development. That is the issue, I think. Last two slides that I have are on the use of nuclear and CT. I told you that I believe CT, we've done CT angiography over the years, we work with that, we've done nuclear over many years looking at perfusion imaging, viability imaging, but the fusion of these two brings us anatomy linking with biology. Early diagnosis of cardiac implantable electronic device generator pocket infection using FDG for looking for inflammation and CT. This is the first article. 86 patients, 46 with suspected ICD pocket infection, 40 with non-suspected infection. All of the patients had a PET CT. Again, the CT for the anatomy, the localization where the ICD exactly is. Then the PET is done to use FDG, glucose utilization, which is a marker of inflammation. And the analysis that they did is they used the FDG activity in the region of the generator pocket expressed as a semi-quantitative ratio, SQR. Here you see a picture. This is the CT scan. And this is the same scan, but now superimposed with the PET study. And you see here where the device is, these hotspots indicating something is going on there. This is inflamed tissue. Here you see another view like that. Some hotspots, as you pick up here, very clearly that something is going on. Here is another one where you have the device, but absolutely nothing on the glucose scan. So there is no inflammation there. And here you see these SQRs that we spoke about. If this is actually very low, very little FDG uptake, very little marker of inflammation, there is no infection. However, in the ones with an infection, that's significantly increased. This is something I tell you is going to go fast in your clinical practice. This is going to move in quickly. Because we have so much difficulties often. When there is an endocarditis, do we have other foci? When there is a device infection, is it infection or if it's just thrombosis on the leads that we're seeing? This is the last article that I share with you. Clinical impact of this Fdg-Pet CT in the extracardiac workup of patients with infective endocarditis. So here you see an example of a patient with endocarditis, and look, here you see the CT scan and superimposed again the glucose scan. There is a very hot spot. This is an osteomyelitis, and the comparison here is with MRI, where you see exactly the same. But this is so easy to pick up. You have the CT scan for your precise anatomical depiction, and you see the hotspot. Here's another one. This patient has a vascular graft. This is now the CT scan. You see the graft, but you don't see anything going on. But here, look, it's very easy to pick it up. Here is a third one. This is a spondylodiscitis in addition to an endocarditis. And you see it also on the MRI. But I tell you, this PET CT for these specific questions is going to be very important. I did not strictly adhere to what I had to share with you because there wasn't that much exactly in valve disease and heart failure. But I tell you, echo is going to move in the direction of three-dimensional imaging. MRI is going to move in the direction of fibrosis imaging that we cannot see, but we can quantify and relate it to outcomes. And I believe nuclear and CT are going to be more and more fused to fuse anatomy with functional consequences or biological activity. Thank you very much.
Jeroen. There is no discussion, so it's my pleasure to introduce John Mcmurray to talk about heart failure 2015, new drugs on the horizon, or beyond the horizon.
Thank you very much, Marco. So now for something completely different, as they say. So I'm going to review just the European Heart Journal, and I'm going to look at in the main papers that it described original clinical studies. These are my declarations of interest. And I've split my talk up to look at papers on prevention of heart failure. There's actually only one of those. Papers on HFpEF. There are two of those in the past 12 months in the European Heart Journal. Then papers on HFrEF. There are a few more of those. And then finally, because there are no papers on acute heart failure, I'm actually going to mention a review about acute heart failure in the European Heart Journal. And I'll try and give a little bit of context around each of these So what about prevention of heart failure? Well, the one paper I can find published in the past 12 months is this one, and it's a meta-analysis of all the statin trials. In fact, if you look at the bottom of the slide, you'll see here a meta-analysis, an individual patient meta-analysis of 17 trials with 132,500 patients included. The average follow-up was 4.3 years. And this was looking at prevention of the development of heart failure in these trials. Now, the development of heart failure wasn't very common because of the very highly selected patients who went into most of the statin studies. That's why a meta-analysis was needed to detect a signal. And as you can see, there was a modest 10% statistically significant reduction in the risk of developing new onset heart failure in the statin trials. I think the interesting thing in this paper was that this risk reduction was equally apparent in patients with a history of prior myocardial infarction and in those who did not have a history of prior myocardial infarction. So why was that? Were statins preventing some sort of subclinical injury, unrecognized myocardial infarction? So the next topic I want to look at is heart failure with preserved ejection fraction. As I said, I found 2 papers that addressed this condition in the past 12 months in the European Heart Journal. One was this single-center study looking at patients with HFpEF and pulmonary hypertension and looking to see whether the PDE5 inhibitor sildenafil might have at least beneficial hemodynamic effects. So the primary endpoint in this study was change in mean pulmonary artery pressure after 3 months of treatment. And as you can see here, sildenafil did not, in these patients, reduce pulmonary artery pressure. And unfortunately, that's a very consistent finding with another larger trial looking at clinical outcomes, symptoms, and exercise tolerance in patients with HFpEF as well. So unfortunately, it looks as though there's no role, hemodynamic or otherwise, for PDE5 inhibitors in people with HFpEF and pulmonary hypertension. The other study that was published on patients with HFpEF is an interesting trial from Japan. It's a large study, 1,147 patients. These are hypertensive patients with heart failure. Most of them had HFpEF. The average ejection fraction was 54%. Most of them had mild symptoms. The majority were in NYHA class 2. And in this study, patients received an angiotensin receptor blocker, olmesartan, added on top of background therapy with, in the majority of patients, an ACE inhibitor and beta blockers. So it was olmesartan versus control, added in the most part to an ACE inhibitor and a beta blocker, had a long follow-up, a median follow-up of 4.4 years. A lot of events, about 30% of these patients had one of the primary composite outcomes. The primary composite outcome was death from any cause, myocardial infarction, stroke, or hospital admission for heart failure. And the red line here shows you the olmesartan group. So what you're seeing here was actually an increased risk of events when olmesartan was added to background therapy, including, as I said, in most patients, an ACE inhibitor. Now, maybe that's not terribly surprising because we know that ARBs on their own were not helpful in patients with HFpEF. We know that adding ARBs to ACE inhibitors in most patients is not a good thing, leads to more adverse events, so perhaps no surprises there. Though we're still left with this anomaly of 2 trials in patients with HFrEF where adding an ARB seemed to be beneficial. Why is that? Why in HFrEF do we have one set of findings, but more and more consistently in hypertension, in renal disease, and now in HFpEF, dual therapy is not good? And I think we will get more information that I think will solve this problem once and for all, because this is a trial that's been running for a long time, a very large trial, very large number of events. It will give us an unequivocal answer, and it's again looking at single versus dual RAS blockade in patients with HFpEF. It will tell us whether CHARM and VALHEFT were wrong or whether they were right. And this trial is currently closing out, and you will see the results of this early next year. So I'm now going to look at heart failure with reduced ejection fraction. There were a few more papers on this type of heart failure. I'll go through them very quickly, just really to highlight them if you want to go back and read them. One was from the Emphasis Heart Failure study. It was a post hoc analysis. It was looking at patients who were recently discharged from hospital before they were randomized in this trial, randomized to placebo or the mineralocorticoid receptor antagonist eplerenone added to conventional therapy in patients with HFrEF. It showed us, as we've seen before, that patients who've recently gone home from hospital are at much higher risk than patients who've not been recently hospitalized, and that in this study, the effect of adding an MRA was at least as substantial in these recently discharged patients as in the more stable chronic patients. This is a little table that Oxford University Press kindly drew up for me, looking at the most downloaded papers in heart failure in the past 12 months from the European Heart Journal. So I've excluded from this guidelines, which were at the top of the list. I've excluded, except for one example, reviews, though those by and large were not particularly highly cited. And by far the most highly cited paper in heart failure, with an average of 727 complete downloads per month, was a trial looking at iron replacement in patients with heart failure who were iron deficient. And you will remember a few years ago, very interesting, controversial study suggesting that iron replacement in iron-deficient patients with heart failure might be beneficial in terms of improving symptom outcomes, improving quality of life, what some people would call soft measures. We were uncertain about this one relatively small trial. Well, to give a lot of credit to these investigators, they did what they should have done, which was to do a second trial, a confirmatory trial. And this trial was published in the European Heart Journal, and this is by far the most cited HFrEF trial in the journal. And in this trial, the investigators were able to confirm that intravenous iron therapy did improve functional capacity, did improve symptoms and quality of life, though again this was a relatively small study and there were not very many deaths or other hard events, though there was an intriguing trend in the right direction in heart failure hospitalizations. I'll highlight a few of the other highly cited heart failure papers, and a few of them relate to LCZ696 or sacubitril valsartan. I'm not going to go into the details of this. Probably most people are well aware of this treatment by now. The Paradigm Heart Failure trial was presented at this meeting last year. It showed that this new type of treatment was superior to an ACE inhibitor, and there have been a few follow-up papers. One was looking at an indirect comparison with placebo. One was looking at mode of death. So we know that this treatment reduces cardiovascular mortality by 20% compared to enalapril, but we also published a breakdown of the different modes of death, showing that LCZ696 reduced both sudden death and death from worsening heart failure to a very similar extent and significantly. And my favorite's probably this one. It's actually not in the league table because it's just been published online, and it's looking at this treatment across the spectrum of age. Now, most trials are criticized because they enroll younger patients who are not as sick as most of the patients we look after. In paradigm heart failure, there was a massive difference in age between, for example, the Asia-Pacific region and Latin America and Western Europe. Where we work in Western Europe, patients are on average 10 years of age older than in those other regions of the world. The oldest patient enrolled in Paradigm was 96 years of age at the time of randomization. And here you can see the effect of LCZ696 compared to enalapril across the age spectrum for all the different endpoints. And you can see that it had a consistent benefit in reducing death and hospitalization, and indeed also in improving symptoms. Now, I'll finish up with saying something about acute heart failure. Now, there was no original paper published in the past 12 months in the European Heart Journal on acute heart failure, but there was a very highly cited review article which was about ularitide. And ularitide is a natriuretic peptide. It's one that is produced in the kidney, synthesized in the kidney. It's structurally related to ANP and indeed derives from NT-proANP, but it is a renal-specific natriuretic peptide. And the reason this natriuretic peptide is of interest is that it is being studied in a very large ongoing trial in acute heart failure called TRUE-AHF. It's one of the 2 drugs being studied in large morbidity, mortality, acute heart failure trials. I'll just finish by mentioning that the European Heart Journal is interesting, I think, to read for lots of other reasons. And you get these very interesting little snippets, vignettes. This is an article by Eugene Broadwald about Adolfo de Bold, who I would say was a forgotten scientist who made a massive contribution to the field of cardiovascular medicine in recent years. This is the man who discovered natriuretic peptides. And we've talked about LCZ696, we've talked about ularitide. This man really is behind all of those developments. And likewise, the journal carried a very interesting article about how the 2 groups who discovered angiotensin II independently, give it different names, came together 75 years ago to agree on a common name. So there are lots of other interesting features in the journal. Thank you very much.
Well, what a wonderful overview this was, John, as always. I really enjoyed that. So we are now shifting, not gear, but towards valve. Alec, don't be so shy. He's usually not that shy. And we are unfortunately a little bit more democratic than we are today. We have no time to discuss and open up for discussions. But it's not like that you think European Heart Journal or heart failure journals are like that. We have actually a lot of appeals we have to deal with as well. Alec.
Thank you, Mr. Chairman, dear colleagues. I'm going to discuss with you aortic stenosis. Here are my conflict of interest. Well, first of all, I'd like to put to you a paper on epidemiology, starting with a relationship between psoriasis and aortic stenosis. And I'm really sorry for my heart failure friend. You present studies with 130,000 patients. Well, here I'm going to present a study in 5 million of patients from Denmark, and we should pay homage to the friends from Denmark who are able to run such fantastic registries. And what the lesson here is, if you look at the incidence of aortic stenosis in the reference population, it's 8 per 10,000. But as soon as you have mild psoriasis, it goes up to 16, and when you have severe psoriasis, it goes up to 21. And clearly, there is a severity of the disease increase in the risk of aortic stenosis. Much higher if you have a severe psoriasis and even if you have a mild psoriasis than the control population. And this persists even after adjustment by many variables. So this shows that psoriasis, once again, has a relationship with cardiac disease. It was known for ischemic disease, some signals also for heart failure, and it brings the hypothesis of the role of inflammation in aortic stenosis even much higher. Very interesting study. Now, we are in Europe, it's very good, we are in London, but we have to look at the rest of the world, and discussing only aortic stenosis in a Western country is not sufficient. We have to be global. I'd like to quote this very interesting study, Remedy, in 13 countries, including also India, Yemen, many countries in Africa. They looked at children and adults, more than 2,000, coming for symptomatic heart disease. And, well, we should say that aortic valve disease is there. It's not very frequent in the kids. It is slightly increasing in the adults, but very far from the prevalence we have in our countries. Now, I'd like to quote a paper from Jeroen, because he is there, he's the president-elect, so we have to be very kind. But it's a very interesting paper because it pushes the interest of multimodality imaging in a very difficult group of patients. You know that there is something like 30% discrepancies in the evaluation of the severity of aortic stenosis, especially in the group of patients with low gradient and preserved ejection fraction. And in the previous ESC guideline, we stress that this group could undergo intervention, but only if severity is assessed after careful confirmation of its degree. They took grossly 200 patients, were sent for TAVI, and they were quoted as severe AS according to the valve area, and the LV was good. And they split it as usual in 4 groups. And you see that with echo, you may find that the LVOT, which is a key player in the calculation of valve area because it is squared, this may look a bit circular. But as soon as you look using CT, you can see that it is not circular. It is elliptical. And when plotted in either only the echo or the echo plus the measurement of the LVOT area using MDCT, you see that there is somewhat of a difference between the final echo, the final valve area. And grossly, there is quite a good correlation between the echo and MSCT valve area. But when you look specifically, you see that echo underestimate aortic valve area by as much as 25% when using the fusion technique. That's very important. And that's especially important in the group of patients with normal flow and low gradient. And when recalculating, re-estimating LVOT using this fusion technique, you reclassify as many as 50% of the cases from severe to moderate. It is not without practical consequences. Of course, I would like to encourage you to read this editorial which accompanied this paper, saying that it's fantastic, it's very interesting, it adds on our knowledge. Because in this group, for example, using calcium scoring didn't help. So it is very helpful, but of course we cannot use it in every patient. We should probably use it in patients where we ruled out measurement errors, when we rule out inconsistencies in the guideline criteria. But when we are really discussing pseudo-severe or severe AS, it could be really helpful. We have to dig on to further study that and to assess its clinical role. Now, of course, you know, I'm not a surgeon, so I'm going to discuss with you briefly the transcatheter aortic valve implantation, quoting this very interesting paper coming from the US. Only 2,000 patients, I apologize for the heart failure colleagues, 2,000 patients coming from the randomized trial partner plus the non-randomized cohort, and they looked at paravalvular leaks. Big problem. It is known in 50% of the case, mild in grossly 40% of the case, moderate to severe, as much as 9% of the case, it was with the previous device. The first factor they identify is that it's not good to have a low cover index. And with a high cover index, large prosthesis, well suited to the annulus, you have less AR. But the big finding in this study was to show that death did increase even if you have mild periprosthetic leakage. This is not consistent with what we know from surgery. It's a problem. Is it a problem with measurements? We know it's not easy to measure these things. But it could be a problem due to other causes. And still, they insist, because they said that even a mild paravalvular leak has a independent prognostic value. So they do insist. But in point of fact, they also showed that you should look at the baseline characteristics of the patient, which may influence the thing. And for example, a patient who already has moderate AR before the procedure will tolerate much better the AR which may occur. So that's interesting. And they showed that there is no real difference if you consider only cardiac death, but it's not good to have some degree of paravalvular leak for rehospitalization, which are more frequent, and it's also better to have no paravalvular leak if you want to recover, to improve your functional status afterward. So now they also looked at the improvement in LV function, and the improvement in LV function is better if you have no or trace AR, and they showed also that the LV hypertrophy will regress much better if you have no AR. So now another paper, which is quite interesting, is a paper showing the use of a device to protect the brain against stroke. That's very important. You know that it is pinpointed as a very important complication. It is this sort of device. I apologize for the quality. It is introduced transfemorally, and it covers the three main branches. It is a randomized study, so it is very good, and they compared unprotected versus protected. They did not perform MRI before, but they performed MRI after, which is probably acceptable. The point is they did not perform MRI during follow-up in something like 30% of the cases, which is probably a limitation of the study. What did they show? They showed that this technique is feasible. You can introduce this device and cover completely the three main branches in 90% of the cases. It doesn't take much time, but there is no difference as regards the major primary endpoint in the group with protection versus the control. You can appreciate that the primary endpoint can be considered as a bit too long, and there is no difference in terms of stroke, clinical stroke. But when you're doing the MRI assessment, clearly there is a reduction of the new ischemic brain lesions in the patients who are protected, and this is even more apparent in patients where the three vessels were completely occluded. And they showed that there is a decrease in the number of single or maximum lesions volume. So there is a protection when using this device, and this protection is accompanied by a decrease in the stroke as assessed by the stroke scale usually observed. There is clearly a decrease early on, and then there is no real differences. And finally, it's quite important for us, because having less MRI images, well, is good, but does it mean something? Having having more influence on the stroke scales, it is important, but having less cognitive changes, it is important, and they did show it. So it's one study in the field, interesting. Now, very briefly, and to finish, I'd like to quote this very interesting paper on the transcatheter heart valve failure systematic review done by Millot. You know that more than 200,000 patients did receive a TAVI. And here, look, they very carefully scrutinize the literature, and they find very few problems during this follow-up. Endocarditis, 34 cases, late embolization, 18, structural failure, 13, compression, 7, thrombosis, 15. Look, go to this paper. It's fantastic. You have very nice images. Endocarditis, quite rare, of course, but surgery was used in only 40% of the cases. Structural failure, very rare, was treated mostly by a transcatheter valve in a valve. Thrombosis, very interesting, rare, delayed couple of months after, treated with success in most cases using anticoagulation alone. And embolization towards the left ventricle, delayed also, of course, needs surgery. And something which is unique, it is a compression after CPR in this patient. So all these data should be collected on a continuous and comprehensive way. That is the rationale for participating into the registry. Now I'd like to finish by showing you two flashlights, because you have to go and read the flashlight in European Heart Journal, what the interventionist can do. We are not crazy, but we are willing to expand the scope of interventional techniques. And in Zurich, you are there, Frank, you combine in a patient transcatheter aortic valve replacement plus repair of an aneurysm plus pacemaker and a bit of stenting and LA appendage closure. That is the image, the final image. This can be done. But let's say, to be a bit more serious, I'd like to show this last slide to tell you that all these techniques, percutaneous technique, do combine very nicely with surgical technique. They compete, of course, but they are complementary, and more patients will be treated by this technique. It is for the benefit of a patient. So this year was a rich year on the field of aortic stenosis in the European Heart Journal. Thank you.
Oh, fantastic. Thanks, Alec. Your passion is contagious. And, well, we love valve disease as well as heart failure doctors. And it's actually really a backbone also for the citation of our journal. And that we moved the impact factor up is actually, in last 2 years, was mainly also due to a really great uptake of citations of valvular disease papers. So thanks so much. And you've seen we are a clinical journal made from clinicians and clinical scientists for all of us and clinicians. So, and that's Francesco. He's from Zurich. He's actually not from Zurich. He's an Italian working in Zurich, and everybody in the world of valves and everywhere knows him. Francesco, your take on the mitral.
Thank you, Frankie. And I take over the mitral topic, which is always a little bit behind. Topic is from mitral clipping to mitral valve replacement. As you know, we are right at the beginning of this experience. It is far beyond expectation, but still very much away from what is the status of TAVI today. So I wish I could give the Alec Vahanian lecture with more data. Now, I will start talking about mitral clip. We all love this technique. We all look and strive to gather substantial data. At the moment, there are a number of publications that have been done in this field, but really there is no contemporary data to support indications and to guide the guidelines. As you see, there are many ongoing trials. They will be probably ready in 2 or 3 years from now. At this time, we really need to have some good publication in the field. And the data is not good enough to access the European Heart Journal. So there is not much you will find in the European Heart Journal about mitral clip. Anyhow, I think these two, I will, in my lecture, I will use Eurointervention as well, which is a sister, is associated journal, more technical, and I think it's also very important to be announced together with the European Heart Journal for more technical papers. So design of trials will be fundamental in the next future. For those who are working in the mitral business, it is absolutely a challenge to properly design trials in this field. And lately, this year has been published finally the EMBARK initiative on designing trials and on assigning outcomes and defining the proper outcomes to collect the data, to provide those who are, like me, involved in these procedures and are enthusiastic about the procedures, to provide us for the good background for the decision making. But don't forget that we're not talking about transcatheter valves. We're talking about valve disease. Valve disease is a continuum of care that starts from medical therapy, goes into the interventions, and who knows how these interventions should be done. This is a good current opinion publication which involved both the cardiovascular surgery and the valvular heart disease working groups of the European Society. And this is a nice paper to read, to have a kind of a state-of-the-art of what it should be the management of patients with severe mitral regurgitations. Now, the question is, however, all this information is very complex because there are a lot of subcategory of patients. Patient complexity is amazing. And as you have seen, as Alec Vahanian just showed you, there are several patients today who undergo combined procedures. Believe it or not, combined procedures are something that in surgery is done every time you operate. You will not accept a patient who comes back from surgery without a complete treatment. So this is going to happen also in transcatheter interventions more and more, providing the regulatory and the financial burdens will be overcome. Anyhow, if you look at data, again, I had to go into Euro intervention to try some clinical data to support our decisions. This is a publication that comes from my previous institution, where we collected data on after mitral clip, showing that patients who undergo the procedure in a more acute phase will have a less benefit from a prognostic standpoint in the future. That underlines once more the importance of properly selecting the patients and identifying the right timing. A couple of papers have been published on neurointervention on valve in a ring procedure with a new device, which is not new for as a device itself, because actually it is the first transcatheter valve ever implanted in humans. But the Melody valve has been implanted very often in the United States. Now there is some experience also in Europe. This paper is from Carlos Ruiz, addressing a patient with a combined residual MR due to a detachment of partial detachment of ring and recurrent MR. And this was corrected by simultaneous implantation of a Melody valve and closing the gap with the Amplatzer. As usual, coming from Carlos Ruiz group, nice and beautiful images are provided. The other alternative that has been in a publication that comes again from our institution now in Zurich, we used a different approach using the Melody valve alone, because Melody valve actually can take advantage of the netted leaflets to create sealing. It is a bit too long to explain the whole procedure here, but this was, I think, a good publication showing proof of concept that you can obtain and improve sealing after valve replacement using the netted leaflets. Guess what? There are a number of devices now which are in the preclinical phase which are using the netted leaflets as a sealing component for the implantation. So I think this is an important paper to read, at least from an historical perspective. We also published some cases of combined procedure, mitral clip and Amplatzer. This is obviously not everyday practice, but there are some patients where you may use these tools in combination. The data, we are collecting the data. Not all patients have a great follow-up. I would say that 70% of them have a sustained outcome. Some of them have hemolysis, so we need to identify the right device. And this is why it is important to publish this data, and obviously will be important in future to collect them in a registry. But this is just an example, a patient who had endocarditis and had an undiagnosed anterior leaflet perforation in addition to prolapse. So after 2 mitral clip, there was still a hole in the anterior leaflet which was closed by the unplaster. This patient is good and well after a few months after the procedure. So this to underline that in this field there is a lot of variability, and this will be almost impossible to put all this experience under the umbrella of properly designed trials. Other interesting application for mitral clip has been presented in this paper from Germany, showing the feasibility of mitral clip implantation to treat SAM. This is a patient in our institution that shows clearly the SAM with insufficiency and acceleration in the outflow tract, and no SAM after the implantation. One topic which is coming now new is that there is a risk of ischemic stroke after mitral clip as well. Now, the mechanism behind is not totally known. This publication, Neurointervention, highlighted the presence of new lesions on MRI after mitral clip, and I think this is a new topic which is similar to what has been seen in TAVI, and this requires further investigation. But for sure, there is a question whether the long time the procedure requires this big sheath with potential for creating coagulation inside of the sheath is probably the problem underlying this phenomenon. Now, obviously, this is all about the mitral clip. Mitral clip is just 25,000 patients around the world. It's not a big number, but still, we missed a lot of opportunities to publish solid data. But what's going on now, there are a lot of other technologies that are ongoing. One more important than anything else is valve replacement. So the first cases of mitral valve replacement, percutaneous mitral valve replacement, have been published on Neurointerventions last year. This is the series of Fortis valve. It is a device which is implanted percutaneously. Transepically, this valve is already retired from the market because after the first few cases there have been evidence of thrombosis. This underlines the fact that before this data can be published with large numbers, very often these devices go out of the market. I think it's important out of the clinical trial. It is very important, on the other hand, to publish this data, to share the data. And you will find this data in a proper publication journal, which is the more mechanical, let's say, journal, which is Neurointervention. You always, I think, if you are interested in transcatheter valve interventions, you have to read also this other publication. Now, there are a lot of promises in the area of valve replacement, and all these promises ask for proper collection of data and publication. I hope in the next year I will be able to present you some data about valve replacement. At this time, we had an effort which was published in April 2015 online, trying to provide a current status of the future of vision, what will be the future of transcatheter mitral valve intervention, and trying to address the complexity of it by defining what would be the complementary role of the two procedures. Is going to be repair or replacement the main way we're going to use to treat patients in the future? There is a lot of technologies here, a lot of advantages and disadvantages, a lot of opinions, not much data. So we start with some opinionated review. There was an opinion from a number of people who have been involved in this publication, who have been directly involved in the preclinical and early clinical trials, trying to guide the further steps. Again, unfortunately, we don't have data. We have only a lot of opinions, but these are opinions based on experience, and I think they still have some value. I want to show you this picture because this is a list of challenges behind mitral valve replacement. it's an amazing number of questions and open issues. So there will be a lot of opportunities for publication in the future. This is not only not only replacement is a hot topic, also annuloplasty will become soon available. In the next future, there will be publications we already submitted on annuloplasty. I'm a bit late, so I will jump on the tricuspid very fast. Sorry if I jump on these slides, which I don't think are very important at the moment. Tricuspid, I only found very little. Tricuspid, however, will be the topic of the next 5 years. Mitral is now present, tricuspid will come. There are other challenges. Now we are learning how to treat patients. And so again, this is only available in a very specialized journal like the Eurointervention. This is a case of a male valve implantation using a trick to overcome the size of the tricuspid valve. And there was one cardiovascular flashlight on European Heart Journal on a similar concept to try to accommodate the large size of the inferior vena cava for the valve by using a hybrid approach with surgery. So having said that, the way in front of us is long. I see light at the end of the road, but we are still in a little bit dark situation. And I think all this is even more complicated when we realize that mitral valve interventions and tricuspid valve interventions are just one short snapshot in the life of a patient, and that to obtain prognostic benefit, there is a need for more collaboration among physicians and to share more data using the European Heart Journal. Thank you for your attention.
Thank you. And now let me introduce Frank Ruschitzka for the concluding remarks.
Well, just I have a few minutes left, just 2 or 3. I think Francesco nicely illustrated that in moving forward in mitral, I think heart failure and valvular disease doctors have to work together and do the trials appropriately, because I think degenerative disease is not the same as functional. It may be totally different, and we need more trials, and the European Heart Journal has, for that reason, published a lot of consensus papers to kind of pave the way how we are moving forward. I just have a very few slides. It's just 2 or 3. And the thing is, I would like to thank you all, because the European Heart Journal is a successful journal. This is a record-breaking congress. Whether you like the number of attendees as a measure of whether a congress is good or not, it's an excellent congress, but it's more than 33,000 people coming, and cardiologists and interested in heart disease, and that's a new record. And the congress and the journal, they march hand in hand. And the journal is now at impact 15, which is at the time when we took over, this is where the arrow is, something we, in our wildest dreams, and we have them at our age, was not foreseeable. And 15, so that's quite good. And we are out there with the other bunch. Zurich and Jack are in the same range. At the moment, we are number 2, but I think when you even take the self-citations out, we would, and that's fair enough. We are too modest in Europe. We take the self-citations out, European Heart Journal would be actually number 1. And so we are there among the top 3. We try to make a journal for clinicians and clinical scientists with the flavor of basic science, which is readable. That's why we have also seen now that we've brought back the old brief rapid communications, which you have probably learned about from Jim Willison in the old years in 2000 from Zurich. We brought that back in, and that's a feature we would like to bring in now that you give us up a snapshot of your research, just 800 words, and it's often very highly cited and readable, because none of us, between 2 cath or patients, can read a 7-page basic science paper, but it's very interesting, and that's how we try to close the gap. And with Marco sitting here, what has been proven to be key to our success is we are family. We are. when you submit a paper now, we can transfer it. If he doesn't make it, we have an acceptance rate of 8%, for God's sake, in the European Heart Journal. So then we can transfer, and who carries the torch is heart failure. Marco took over from Dirk van Veldhuizen, and the Heart Failure Journal is the #1 heart failure journal in the world. So when we tell you guys it's just can't make it to European Heart Journal, but go to EJHF, most of you accept that. And we have also seen, Jeroen has shown most of his papers from the European Heart Journal Cardiovascular Imaging. Don't forget, we forced everybody now from going to an echo journal to a new imaging journal, and that's been proven to be very, very successful. This is where the future is. And all the other journals are doing very well. And I think it's the success of the family, it's the success of those, of all of you who have contributed, the deputy associators who gave these excellent lectures today, the reviewers of all of you, many of you here in the room that make that work for free these days, who does that and review the journal. Without that, that wouldn't be possible. And that's why, in the interest of time, I just want to call it a day. I just want to, with one thing, the guidelines are key. John Mcmurray's guidelines were the best cited and most downloaded guidelines we ever had in the European Heart Journal. So there are new ones coming, there are new records to break, but that's important. We have the Year in Cardiology, where we try to sum up, as today, the certain specialties, and they are very well cited and downloaded as well, and been proven to be a key to the success of our journal as well. And with that, I just want to send out to all of you that we can't accept most of your papers because the acceptance rate is just 8. Many of you will be angry at us, but at the same time, when you get in, you are proud that we have a high impact journal. That's the way it works. And Congress and journal work really march hand in hand. Thanks to all of you. Thanks to all of you for the wonderful session and the contribution, and for coming here and supporting our journal in the future. Thank you very much.
Thank you, Frank.